Hello, I'm John Chen, Professor of Ophthalmology and Neurology at the Mayo Clinic in Rochester, USA. And I'm joined by my colleague and friend, Freeman Paul, who's a professor of clinical and experimental neurology and group leader of the Clinical Neuroimmunology Department of NeuroCure Clinical Research Center at Charité, Germany. Today, we're going to be offering some practical insights for the early diagnosis and treatment of NMOSD. Our first topic, understanding the clinical features of presenting symptoms of NMOSD. And as a background, we all know the clinical hallmarks of NMOSD. Classically, it's acute severe optic neuritis, severe transverse myelitis, and more recently, it's been recognized that NMOSD can cause other symptoms, including areopostrema syndrome, where patients can have hiccups, vomiting, nausea. That occurs in about 20% of patients. And with NMOSD, the disability comes from discrete attacks. Often after an attack, the recovery is only partial and the disability increases with each relapse. And it's different from multiple sclerosis where you have potentially a progressive phase where you can have disability over time independent of attacks. The drawback of NMOSD is that 80 to 90% of patients will have a relapse, often within the first 3 years of the initial episode. And therefore, establishing a diagnosis of NMOSD early on is very important to counteract that acute attack and to start chronic immunotherapy to prevent future attacks. So Friedman, we have some wonderful questions from the audience about the clinical features and presenting symptoms of NMOSD. The first question we have is, can you explain the underlying pathophysiology of NMOSD and how it differs from other demyelinating diseases such as MS and MOGAD?
NMOSD is a rare disease in contrast to multiple sclerosis. There are worldwide between 200 and 300,000 people affected in contrast to multiple sclerosis, with more than 2 million people with this disease. And the key discriminating feature on the level of neurobiology and histopathology is an autoantibody-mediated damage to the astrocyte in the central nervous system. So autoantibodies, IgG antibodies that swim around in the serum of these patients, so to speak, get access to the central nervous system with the help of T cells through a leaky blood-brain barrier and can then reach their target antigen, the apoprotein-4 water channel on astrocytes. And this causes detrimental subsequent damage to neurons, to axons, to oligodendrocytes, with the relevant clinical symptoms that I'll describe now in very few words. And one of the key clinical symptoms is optic neuritis, uni or bilateral optic neuritis, monophasic or recurrent. Another key clinical symptom is myelitis, often severe myelitis with paraplegia, massive bladder bowel problems. And another less frequent symptom is affection of the brain and brainstem, as you already mentioned in your introductory statement, John, with areopostrema lesions that can lead to intractable vomiting, hiccups, nausea, and a few other symptoms.
Our second question is, what are the most common initial symptoms of NMOSD that should raise suspicion in a clinical setting, particularly in the ophthalmology clinic? How quickly do they progress?
So a patient presenting with impaired visual acuity, with eye pain and symptoms around the eye, so to speak, will present either to a neurologist or to an ophthalmologist. And especially when it comes to eye symptoms and the patient is seen by an ophthalmologist, it's really crucial that also the ophthalmologist is aware of a possible NMOSD diagnosis. When a patient presents with transverse myelitis, with sensory symptoms, motor symptoms, bladder bowel dysfunction, or a combination of these symptoms, the patient will most likely present to the neurologist / to the emergency room because it's a severe situation, a really serious situation then. And in that case, the neurologist will take over and kind of trigger the appropriate diagnostic procedures. Also brainstem syndromes, as we just discussed, hiccups, nausea, vomiting, sometimes also narcolepsy, a very rare symptom, can be suggestive of NMOSD.
So you had mentioned earlier in the prior question that MS is so much more common than NMOSD. So again, optic neuritis is going to be probably more commonly MS. So what are elements of optic neuritis that make you think maybe this is NMOSD? Got to explore more further.
So there are several clinical symptoms that would kind of draw my attention towards an NMOSD diagnosis. This is first of all a bilateral affection of both eyes or both optic nerves. This is a severe clinical presentation. This means loss of visual function, visual acuity down to no light perception in some cases, or in many cases, by the way. And another criterion that should drive a kind of diagnostic procedures towards NMOSD is the poor recovery of the attack, even if high-dose corticosteroids are given, plasmapheresis. All these features should kind of trigger an NMOSD diagnostic pathway.
No, I agree completely. I think these features are very, very helpful. The drawback is, of course, sometimes an NMOSD can be a mild optic neuritis, and so there is overlap. But I agree, when you have that really severe optic neuritis and there's no light perception, the radar, the antenna go up, this is really concerning for NMOSD. So the next question is, how can OCT be used in the identification of NMOSD-related optic neuritis? I can just say a couple of comments as a neuro-ophthalmologist. I love OCT, and I get it on every single patient with vision loss, especially optic neuritis. And in the acute setting, I feel like OCT can be helpful because sometimes you can see that mild swelling that can occur with optic neuritis. Even visibly, you can see in about a third of patients with optic neuritis, but OCT can sometimes pick it up even more subtle thickening, about that 10 micron that's hard to see visibly. And sometimes that can provide an objective evidence that this is an optic neuritis attack, or at least an optic neuropathy. And then I like to track them over time. Over time, I see a lot of retinal nerve fiber layer and ganglion cell loss. Again, provides objective evidence that this was optic neuritis. And with NMO, they tend to have very, very severe thinning, and that can be a tip-off too. Friedman, how do you use OCT in the clinical practice? And also, I know your group does a lot of research on OCT and NMO. How does that factor in?
Yes, thank you for that question, John. Yes, I also love OCT. My group loves OCT. We do it on every patient that comes in to our outpatient clinic with MS, NMOSD, MOGAD, and other conditions that affect the eye. Yes, I fully agree. I think in the acute situation, if there's a subtle thickening in OCT, this can be very helpful, to adjudicate whether there's a true attack of optic neuritis. But I think with regards to NMOSD, it's more relevant on the long term. As you just said, this very steep kind of slope of retinal thinning that occurs subsequent to an attack of optic neuritis. I think for a discrimination between an optic neuritis related to NMOSD versus an optic neuritis related to MOGAD or MS, it's not that helpful, although, and this is work that was nicely done by you and your group, you have shown that in MOGAD, the acute OCT, the swelling, the massive swelling of the RNFL could be helpful to discriminate between MOGAD ON and multiple sclerosis ON. So to sum it up, in NMOSD, yes, we also do it in acute attacks. We do it regularly once a year, but the added value for me is more in the long-term monitoring of the disease.
At what point should an ophthalmologist refer a patient with suspected NMOSD to a neurologist or a specialist center?
This is a very relevant question. Thank you for that, John. And to be honest, we frequently have a problem with this in Germany. Yeah, many patients, looking back at their history of attacks, at their history of NMOSD, they often present to an ophthalmology clinic or to a private practice with a first ever optic neuritis, be it a unilateral or a bilateral affection of the optic nerves. And in many cases, they are diagnosed with optic neuritis, and that's it, okay? And no further diagnostic measures are taken. So there's no antibody testing, there's no MRI, there's no CSF analysis, et cetera, And this causes a relevant time loss until the correct diagnosis is made. So what I think needs to be done, we need to educate our ophthalmologists, we need to work with them more closely, interact with them more closely on these specific cases of patients with a neurological condition like NMOSD presenting to the ophthalmology department with the first ever attack of optic neuritis.
Thanks, Friedman. I completely agree. I think, our approach to optic neuritis has changed so much. Our acute treatment is different, our chronic treatment is different, and I agree. Every single patient with optic neuritis, I also refer to our neuromyelologist here at Mayo Clinic, but I think it's imperative for all ophthalmologists to consider that, because we have to think about these other entities. It really changes our long-term treatment.
So as you said, the challenge is not when a patient has additional symptoms like myelitis or other symptoms suggestive of a neurological condition. The challenge is this first ever optic neuritis only kind of attack. That causes problems.
No, I completely agree, because even if, let's say, they recover and they're just that fortunate, lucky person with optic neuritis with NMO that recovers, if they're not diagnosed with NMO at that first attack, their next attack could be that debilitating attack that leaves them bilaterally blind or wheelchair bound. So that early diagnosis is key, because then we have actually very good treatments now to prevent new attacks, which we'll be talking about later.
Absolutely, yeah.
Now we're going to talk about the initial assessment and differential diagnosis of NMOSD. When you have a patient that has a clinical or history that's suspicious for NMOSD, the first thing that you're going to want to do is check for the aquaporin-4 antibody in the serum. Because there's a lot of overlap between NMOSD and MOGAD phenotype, oftentimes we'll check both the aquaporin-4 and MOG antibody simultaneously. And if the antibody is positive for aquaporin-4 and they have a clinical symptoms that's suggestive of NMOSD, you really do have your diagnostic criteria for NMOSD. If they're positive for MOG, it might be MOGAD. Of course, it's important to be doing a very good neurologic and ophthalmic exam to make sure that the potential activity is suggestive of NMOSD. We have MRIs and OCTs to help us as well. And we want to look for alternative diagnoses and red flags that might suggest a different diagnosis. There's a lot of NMOSD diagnostic challenges. For example, the aquaporin-4 antibody can be affected by the assay methods and other things that could potentially change the status. There's a lot of diseases that can mimic NMOSD that you have to think about. Patients with NMOSD may only have a mild optic neuritis attack, and yet that could be the first manifestation of disease. The aquaporin-4 antibody, again, is quite good, but it can take sometimes 2 weeks to return, and so you actually have to make your decision on your acute therapy even before the aquaporin-4 antibody is back. And there's some countries that don't have access to the aquaporin-4 antibody. Lastly, there's some patients who have NMOSD phenotype that are actually negative for aquaporin-4 and for MOG antibodies. These patients are definitely a challenge, and you want to make sure that they meet the diagnostic criteria for NMOSD. So Friedemann, the audience submitted some great questions about the initial assessment and differential diagnosis of NMOSD. The first question we have are, what are some common conditions that NMOSD is mistaken for, and how can clinicians differentiate between them?
The most relevant differential diagnosis, as we discussed earlier during this conversation, is of course multiple sclerosis, with some overlap in clinical presentation, with some overlap in imaging findings on MRI and perhaps OCT. And another relevant differential diagnosis is MOGAD. And because we have the opportunity for antibody testing and to demonstrate these or to find these highly specific autoantibodies in the patient's serum, we can make a clear diagnosis in case the antibody is present in serum. It might be more complicated in case of so-called seronegative NMOSD. This means the clinical presentation resembles or is compatible with NMOSD. Also, the imaging findings are compatible with NMOSD, but the patient lacks the antibody to aquaporin-4 in serum. And these cases are indeed more challenging, and we then have to refer back to the diagnostic criteria published in 2015, also by colleagues from the Mayo Clinic, that have also described a diagnostic algorithm for patients without antibodies or in whom the antibody status is not known, because you, John, nicely referred to the fact, and this is really unfortunate in many parts of the world, that neither patients nor physicians have access to autoantibody testing. Another point that is of relevance here is that NMOSD may overlap with several or can occur in conjunction with several rheumatological disorders like lupus erythematosus or Sjögren's syndrome or a couple of others. So this also needs to be taken into consideration. And other diseases like sarcoid, Susak syndrome, and there's a long list, we cannot touch upon all of them here now, are to be taken into consideration as relevant differentials of NMOSD. But in the end, it comes down to the kind of clinical acumen of the physicians that examine the patient. It comes down to the awareness for this rare condition and then to kind of initiate the appropriate tests.
Our next question is, what are the key imaging and fluid biomarkers for NMOSD diagnosis, and what challenges exist in interpreting them?
Yeah, very good question, because as we just said, we'll start with a clinical examination and then we will kind of trigger or order the appropriate tests to kind of nail down the diagnosis or rule out this diagnosis of NMOSD. And as we discussed, first of all, that's the aquaporin 4 IgG antibody test in serum. It's very important to do this in serum. It does not make sense to test for aquaporin 4 antibodies in the CSF. Yeah, you can save time and costs and whatever and confusion. Yeah. The next point is the MRI. There are several characteristic MRI features that point towards NMOSD, like if a patient presents with myelitis, this could be a very long cord lesion, what we call LETM, longitudinally extensive transverse myelitis, so an inflammatory lesion spanning more than 3 vertebral segments. There are certain features when you do orbital imaging, for example, a long inflammation in the optic nerve that also reaches or spreads out to the more posterior parts of the optic nerve, sometimes even involves the chiasm. And when it comes to brain MRI, it is a bit more complicated in some regions. This also depends on, ethnic background. And so there are tumefactive lesions, there are lesions near the ventricles, but usually in NMOSD patients, we do not see these classic MS-like lesions, for example, Dawson fingers in the corpus callosum or inferior temporal lobe lesions, etc. But in single incidents, in single cases, it might be very challenging to discriminate between the two conditions based upon the MRI findings.
I think the benefit we have of NMOSD is the aquaporin 4 antibody is so specific, especially if it's done with a cell-based assay. It's got such good specificity that if it's positive, that's going to be NMOSD. That's unlike our MOG antibody. For MOG antibodies, which is your MOGAD, we have a good assay for that. It's 98% specific. But again, when you've got a disease like MS that's 10 to 50-fold more common than NMO and MOGAD, then all of a sudden that specificity, that positive predictive value is a little bit less helpful for the MOG antibody. Or again, the aquaporin 4 antibody is so specific.
Absolutely, I fully agree. And I think it's important to speak a bit about who should be tested, when should we test, which assays should we use. And as you already mentioned earlier, John, ideally we would test our patients in a cell-based assay. Yeah. So there are fixed cell-based assays, live cell-based assays. Fixed cell-based assays are available commercially by many labs in the US, in Germany, in Europe, and elsewhere. Live cell-based assays are usually only done at academic institutions or academic labs. So if possible, physicians should test their sera or the sera of their patients in a cell-based assay. These have both high specificity and sensitivity, over 90% on average across labs. So this is good. The problem is that there are other types of assays like immunohistochemistry or immunofluorescence or ELISAs, probably most widely used in other regions of the world. And we do have a problem with both sensitivity and specificity of ELISAs in terms of false negatives and false positives. Now the question is what to do if only an ELISA is available. Yeah. And my take on this is, but I'm happy to hear your position, John, that if you only have an ELISA available and the clinical scenario resembles or suggests NMOSD, the colleagues should do an ELISA. It's better doing an ELISA than doing nothing in terms of testing, although they should be aware of the, let's say, fallacies and of the problems of these ELISAs. Yeah.
No, I completely agree as well. Again, the ELISA is still fairly good. And so again, if the clinical phenotype matches, that's going to be your diagnosis. But the clinical phenotype doesn't match. That's when I think trying to reach out for that cell-based assay is key to either confirm or refute a diagnosis of NMOSD. We've certainly had patients referred for NMOSD who had a positive ELISA antibody who ended up being a false positive, and they had, other more vague symptoms like fibromyalgia and other things like that. But it's important to have that correct diagnosis because our NMOSD patients are going to be put on chronic immunotherapy. And obviously, if a patient doesn't have NMOSD, these chronic immunotherapies can potentially do harm.
I fully agree, and from time to time, it might be reasonable and recommended to repeat the test in case the initial test is seronegative, because in some cases it might be seronegative if the blood is drawn after high-dose corticosteroids and or after plasmapheresis. This could influence the test results, yeah. So I think it could be wise to retest after a couple of weeks or months or in another assay or another lab if possible, yeah. Although, and there was a nice study by your institution, the Mayo Clinic, John, a few months ago, that the rate of seroconversion from initially negative test results to positive test results is very low in aquaporin 4 NMOSD. Nonetheless, what we do here in Berlin, in Germany, in case the clinical scenario suggests NMOSD, the initial test is negative, we retest the patient after a few weeks or months.
No, I agree completely, Freedom. And again, even though that rate was very low, I think we found about 0.3% in about 1,000 tests. Again, that's still, you're picking up, some patients that could potentially have NMOSD. And so if that clinical phenotype is very suspicious, I think it's definitely worth rechecking again. Our next question is, are there prognostic factors that can inform the course of the disease and risk of further attacks already at the time of diagnosis?
This is a very relevant question, and this question is asked by every patient I see with NMOSD or with suspicion of NMOSD. The answer is yes and no. Yes, because we know from large cohort studies from the US, from Japan, from Korea, from many regions of the world, that there are certain prognostic factors. One of the most relevant prognostic factor is the presence of the autoantibody, the aquaporin 4 IgG in serum at the time of first clinical manifestation. There's a nice study, again, from the Mayo Clinic now almost 20 years back, showing that patients with the first attack of a long choroid lesion, the first attack of myelitis showing this LETM, have a high risk of recurrence in case they are antibody positive, in contrast to seronegative patients, which also means that in case you have a first and a single attack, the patient tests positive for the aquaporin 4 autoantibody, you must start preventive immunotherapy immediately without any further delay. Of course, then there are certain ethnic, geographic, and other environmental factors that probably influence risk of recurrence or attack risk. For example, Black people or African Americans seem to be more severely affected, have to have more severe attacks. In certain regions of Asia, when we look at imaging findings, there seems to be a higher proportion of patients presenting with infratentorial lesions or lesions in the spinal cord, the cerebellum, and the brainstem, etc. This is interesting from a kind of epidemiological standpoint. This is less relevant for counseling of individual patients. What counts for an individual patient is the severity of the initial attack and whether, with all means that we have, the patient has shown good or less good recovery. And the second point is, does the patient have the autoantibody to aquaporin 4 or no?
I completely agree. What are your thoughts on other markers like serum GFAP? Do you think they're going to be helpful in predicting future attacks or outcomes?
Yes. I mean, we have, again, good cohort studies, some of them from the pivotal trials on the new drugs, that GFAP, so this is an astrocyte marker, that this is associated with attack risk, also correlates with new lesions on MRI. I think that within 3 to 5 years from now, we will probably also use GFAP in individual patients for treatment monitoring.
I agree as well. I think we're going to get better biomarkers for predicting, relapses and severity. Perhaps not quite there yet, but it's an exciting field with all the advances that have been going on.
Yeah.
Now we're going to talk about the early management of NMOSD to mitigate symptoms and reduce the risk of further attacks. When you have NMOSD, treatment really comes into two phases. The acute attack, whether it's the severe optic neuritis or transverse myelitis attack, we're going to want to treat that acutely to try and get recovery from that attack. And then there's the chronic immunotherapy to prevent relapses. So when a patient presents with an acute attack, we treat patients with IV methylprednisolone or very high dose oral prednisone, 1,250 milligrams of prednisone or 1,000 milligrams of IV methylprednisolone, usually for 3 to 5 days. With NMOSD, the attacks are so severe and the recovery is pretty poor that we usually add on plasma exchange or PLEX to try and get as much recovery as possible. Rarely we'll consider IVIG if the steroids or plasma exchange is contraindicated. The long-term management is very important as well. 90% of patients with NMOSD are going to relapse. And again, every attack can be very disabling, and therefore all patients need to be on long-term maintenance therapy. Fortunately, we now have 4 FDA-approved medications for relapses, for preventing relapses in NMOSD, all proven to be very effective in randomized clinical trials. We have eculizumab and ravulizumab, which are both monoclonal antibodies against the C5 complement pathway. We have enobalizumab, an anti-CD19 monoclonal antibody, and satralizumab, an IL-6 monoclonal antibody. And again, all these have been proven to reduce relapses in NMOSD and very effective. We've also been using rituximab for many, many years, which is a monoclonal antibody against CD20 B cells. It's improved in Japan, used off-label in many countries, but again, a very effective medication for NMOSD. So it's very exciting that we now have these treatments to prevent relapses in what was once potentially fatal disease. We can certainly control these attacks and prevent this long-term accumulation of disability from relapses with these treatments. So Friedman, let's discuss some questions submitted by our audience about the management of NMOSD. The first question is, what are first-line treatment options for acute NMOSD attacks, and how should clinicians decide between them?
Very good question. Thank you, John. I would like to make 2 points. First of all, the point, time is tissue. This means we need to start attack treatment as fast as possible, as soon as possible after the onset of clinical symptoms, because the later we start, the lower the chance of a good functional outcome. Yeah. So usually we start treating with high-dose corticosteroids, high-dose intravenous methylprednisolone, 1 gram per day for 5 days. However, we have seen in our large database within the German neuromyelitis optica study group NEMOS that very severe attacks, especially very severe myelitis attacks, benefit from immediate implementation of apheresis therapies like plasma exchange or immunoadsorption. Yeah? Especially when a patient has responded well to apheresis therapies during a previous attack. Okay, so to sum this up very briefly, start as soon as possible. Do not allow for any delays to occur, even if it's over the weekend or on Friday evenings or so, if doable. And then perhaps start with high-dose corticosteroids, but then rapidly escalate or add plasma exchange to high-dose corticosteroids, or in case of very severe attacks, give these 2 approaches in parallel or start with apheresis therapies up front.
I think it's very easy for a patient who has a known diagnosis of NMOSD who comes in with a relapse. We know to treat them very early with steroids and often simultaneously with plasma exchange or shortly after. What about that first patient who comes in with severe optic neuritis, they're no light perception, that severe transverse myelitis, they're quadriplegic? When do you escalate therapy to plasma exchange? Because the antibody testing will often take 1 or 2 weeks to return.
So if there's a concomitant occurrence of an optic neuritis with myelitis/brainstem affection or so, I would probably combine steroids or with apheresis therapies or start plasma exchange up front without any further delay. Even if I do not have the antibody test, that also takes a few days here at our institution. Yeah, because if the entire clinical picture suggests MS, NMOSD, MOGAD, in the end, in all these 3 conditions, we would do more or less exactly the same. Yeah, especially if we do not yet know the antibody status. So I wouldn't lose time waiting for the antibody test to come back.
And then for ophthalmologists in the audience, if it's a severe optic neuritis, no transverse myelitis, but just a severe optic neuritis, when do you usually consider adding on plasma exchange for those patients?
So I would start with high-dose corticosteroids, but if there is no kind of upward slope in terms of improvement within 2 to 3 days maximum, I would do plasma exchange from day 3 on probably. I mean, the problem is, as we all know, from clinical experience, that the improvement that comes with corticosteroids lags behind, okay? Which means that we do have patients that show some improvement after a week or after 2 weeks, okay? But there's no guarantee that this will happen, okay? Which means that we have to act from day 2 or from day 3 with more aggressive therapies and should not wait for this tentative improvement to occur within 2 weeks or so before we take action and escalate.
Our second question is, are there guidelines or recommendations on how to manage patients experiencing an acute attack whose symptoms do not improve, despite treatment with all currently approved agents?
Each and every attack needs to be avoided if possible. It needs to be treated as aggressively and as aggressively as possible. Yeah. So what we do here, as we just discussed, we combine therapies. We escalate very rapidly to apheresis therapies. We also consider adding complement inhibition in the acute setting. Yeah. We do not have much experience with this, but from a mechanistic standpoint, I'm happy to hear your view on this, John. From a mechanistic standpoint, because this is a far downstream effect in the damage cascade of the NMOSD attack, it makes sense, I think, to try complement inhibition. And in some patients, we start preventive immunotherapy with, for example, rituximab or others, right within the kind of fading out of the attack, so to speak.
In terms of the complement inhibition, I think that's a very intriguing idea, and it's something we don't regularly do, but it makes mechanistic sense. And again, I think clinical trials will be very important for proving the efficacy of that. Our next question is, how do you incorporate the latest research and clinical trial data into your practice when selecting among the different long-term treatment strategies for NMOSD?
We have no head-to-head trials comparing the new drugs, which is a problem. Yeah, we only have registries and case series and so, yeah. But we do have consensus and guidelines statements or guidelines from our network in Germany, the NMOS, and other societies that are very helpful. Yeah, although not all of these statements are backed by RCT data. This is also important to mention, but they were drafted and published by clinical experts with the clinical knowledge and acumen to treat and manage NMOSD that have been working in the field for decades, many of them. So I think this is something we can rely on. And again here, we need a collaborative interaction with colleagues from other departments, from other subspecialties of medicine. And we also need to put the patient in the center because, for example, when it comes to a decision as to which preventive immunotherapy to use, we need to know what the patient wants. Yeah, is it the mode of action that is more relevant to the patient, the frequency of administration, the route of administration, IV versus sub-Q or whatever? All this needs to be discussed with the patient. And as an MS, we need a process of shared decision making because in the end, it's the patient who takes the drug or who does not take the drug.
I think for us, we might not necessarily always start with the same medication first, but what's important is if they relapse on that medication, then we can switch that patient to a different class, a different mechanism of action, and also have good evidence that the medication will work. Is there a particular medication that you tend to always start with, or is it really kind of dependent on the patient?
It depends on the patient and the history of the disease. And now we tend to use only the approved on-label therapies, for various reasons. But there is no kind of algorithm that we start with anti-IL-6 and then move on to B-cell depletion or vice versa. It really depends on the entire circumstances and the patient preference.
Our next question is, what are the recommended follow-up strategies for patients with NMOSD to monitor treatment effectiveness, disease progression, and the need to switch to therapeutic regimen?
First of all, it's the clinical observation, the clinical follow-up, are there attacks or are there no attacks? This might be tricky in some situations, but on average, it's relatively easy to adjudicate an attack. An additional monitoring with regular MRI follow-up or regular biomarker follow-up is a bit problematic because we don't have good data on this in NMOSD. My personal position on this is that in contrast to multiple sclerosis, I would not advocate irregular MRI follow-ups in patients who are otherwise clinically stable. There might be an indication to do an MRI to kind of check for side effects. I mean, there has been no case of PML with these new drugs, but you never know what will happen in the future. So for safety reasons, in case of a suspected attack or a pseudo attack, and it's difficult to rule out whether it's a true attack or a pseudo attack, an MRI of course makes sense, with GAD of course in that scenario. But I would not do a kind of schematic like once a year an MRI or so. I think this is not feasible and not backed by data. With regards to the antibody titers, again, many patients ask about the antibody titers. They want to know if the antibody titer goes down or goes up or is stable or whatever. Again, there are between test variations, fluctuations that need to be taken into consideration. And the antibody status or titer alone is not a good predictor of therapeutic response and of disease or attack risk.
No, I agree completely, Friedemann. I know our group recently published that study kind of following aquaporin-4 antibody titers over time. And what's interesting is that 90% of them remained seropositive, so the bulk are going to remain aquaporin-4 positive. But the 10% or so, 9% that became seronegative, the drawback is 50% of them still became positive again later. So even if you become seronegative, you're not in the clear. And we did have some patients who became seronegative who still actually had an attack of NMOSD. So following those serologic markers in aquaporin-4 NMOSD just doesn't seem to be that helpful. So our last question is, how long should patients typically remain on long-term biologic therapies, and what factors influence the duration of therapy?
The answer is we don't know. Another answer is it's a dangerous disease. Especially the aquaporin-4 antibody positive patients. This means that we should implement immunotherapy, maybe not lifelong, but for very long periods of time. And even after, say, 5 years or so of clinical stability without attacks or so, I would be very, very hesitant to stop immunotherapy, because once you stop immunotherapy, even in those patients who are stable for a long time, the disease may flare up again and may cause problems. Of course, again, it comes down to individual decisions, also comes down to patient preferences, but on average, for me, in aquaporin-4 antibody positive patients, this is a lifelong immunotherapy, lifelong preventive immunotherapy.
The drawback is when you have a relapse, again, they can cause so much disability, even if you catch them early on. So I agree, we typically do very, very long, usually lifelong therapy as well. How do you deal with patients who are becoming pregnant with NMOSD, aquaporin-4 positive disease?
So we've had a couple of cases. One case who was on rituximab, and this kind of covered her over the vast part of the pregnancy, and then we resumed immunotherapy right after delivery. And it worked well, and there are other cases I've heard of. And the other option is azathioprine. It works really well, and it seems to be safe and well tolerated during pregnancy. Also with regards to the effects on the baby. So we've had 2 pregnancies with azathioprine, and it went really well. I would advise against stopping immunotherapy before a woman with NMOSD wishes to conceive. I think this is dangerous.
Well, Friedemann, I think that was our last question from the audience. I really enjoyed having a chance to chat with you about NMOSD and getting this chance to see you.
Likewise, thank you very much. I really enjoyed the conversation. I hope to see you soon again.